You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
My name is John Doane. I'm certainly happy to be here with Sonny and Robert tonight talking about KLEx, a study that Sonny was involved in. I'm a practicing cataract and refractive surgeon in Kansas City.
Thanks, John. Thanks for the introduction. Yeah, this is Sonny Goel, and I'm a practicing cataract refractive surgeon in the Baltimore, Maryland area. I've been doing LASIK surgery for, if you could believe it, 25 years, and SMILE laser eye surgery now for about 6 years. And I'm a big fan and very passionate about SMILE surgery. And, you know, one of the things that we're noticing is when new SMILE surgeons start the procedure and they're experienced LASIK surgeons, they can run into some difficulty early on, and then they question why they get into SMILE. So I'm hoping that John, you, I, and Rob can answer some of those questions for them.
Yeah, I'm happy to be here. This is Robert Lin, founder of IQ Laser Vision, with practices in Northern California, Southern California, and Houston. I'm also a emeritus professor at UCLA School of Medicine. So SMILE is an amazing procedure. Our surgeons have performed over 27,000 SMILE. And in my mind, has so many advantages compared to any of the other refractive procedures.
Well, awesome. So with that, let's kick it off. So today we're going to be talking about overcoming SMILE intraoperative challenges. And before we get to that, I think it's probably good to go through some of the basics about SMILE and go through actually some evidence-based guidelines for keratorefractive lenticule extraction surgery that was actually published in April of 2025 in the Ophthalmology Blue Journal. This was an amazing study. It was pioneered by the folks at the Chinese Refractive Society. And they included 44 global experts looking at 8 literature databases, 5 clinical guideline databases. They looked at over 250,000 studies were reviewed, and over 609 studies were included. And so if you haven't seen this article, I highly recommend you go back to the Ophthalmology Blue Journal, April 2025. What did you guys think about this when you saw it?
I think this really highlights what we've seen in our practice in terms of the outcomes and the safety. So we're definitely in line with the findings in this study.
I would say that I find it just a remarkable study. How deep they went, how many articles were reviewed for this, and then just the level of depth they went into each individual subject was really impressive. And I have to say that I think, as Robert said, this really falls in line with what we believe with the study. I did mention early on, I've been involved with SMILE now since about 2009, and they got involved in the FDA investigations in 2012. So it's been very interesting. It's kind of an uphill challenge for American surgeons to convert to another procedure when refractive volumes are down. But I'm certainly glad that we did the switch. And looking at this study, it really represents much of what we found over the years. I'm really happy that the Blue Journal came out with this article.
Yeah, John, you raised a good point about adopting new technology in a down market. Before we get into the study itself, I got into SMILE in 2020 as a differentiator against the corporate LASIK procedures, corporate LASIK providers. And I found that it was a great way to create a kind of a blue ocean strategy as far as letting me offer something new that they weren't offering.
I think this is just so emblematic of the difference between a flap and a non-flap procedure. Since we're just doing an incision of 60 degrees versus 270 to 300 degrees, and at a smaller diameter, we're impacting fewer corneal nerves. And I think the studies are clear enough at this point that there's no doubt that we have less corneal anesthesia with SMILE than we do with LASIK. And LASIK is a wonderful procedure, but if we can make any incremental improvements, I'm all for it. So this study really rings true to me that preserving more corneal nerves is ideally what we'd want to do, and we can certainly do that with SMILE.
For myself, the reason I started doing SMILE is because even though LASIK is, as you mentioned, is an amazing procedure, I had LASIK in 1997, changed my life because my eyes are so dry from contact lenses. So the LASIK actually improved my dry eyes. But after performing over 60,000 LASIK procedures, the number one complaint I have from my patients is dry eye symptoms after the procedure. And usually it's short term, but it can last after 6 months and even years down. And it's the highest reason for patient dissatisfaction. in my practice. So I was very happy when we started implementing Smile. We give our patients 2 boxes of tiers, and then they come back and they ask for more tiers. They want free tiers or they have to buy tiers. And after we implemented Smile, we didn't have that. So for me, the proof is in the pudding. They're not asking for the artificial tears, and their eyes are not dry. This totally makes sense, these diagrams and all the science. But from a clinical perspective, this is the difference we're seeing. And that's why we always recommend Smile over LASIK if they qualify for both procedures.
Yeah, and we
Yeah.
do the same. In addition to the better dry eye issue, the other thing that's really amazing about Smile is just the ability to get back into their activity the very next day. There's no restriction of activity because there's no any worry about flat movement. And so I tell them you can hit the beach, hit the pool, hit the gym, wear eye makeup all the very next day without worrying about anything moving. And that messaging really resonates with patients. So that has to do with better corneal biomechanical properties and just having no flap, and therefore no flap related complications.
Yeah.
Point well taken, Sonny. The other thing that goes along with that is, since you're not going to dislodge your flap, all the issues about flap complications go away. You don't need corneal shields. You don't have to worry about eye rubbing and dislodgement of the flap. It's user friendly and surgeon friendly.
Yeah, I would add 2 more things. First of all, you're going to have much less potential DLK because you're not lifting up a flap. You're not exposing the tissue. You're not going to have as much epithelial ingrowth, right? So these are 2 reductions. And in terms of, patient comfort, during the procedure, it's very comfortable because of the Visimax laser. It's a low pressure system. And plus the incision's so small, you don't have that irritation. Patients, with our LASIK protocol, it's like you have to go home, take a sleeping pill or take the Xanax, keep your eyes closed for 6 hours. Your eyes are going to be watery. We don't have that with Smile. Basically, they walk out without a shield, and basically, they have very little discomfort, if any, and they just feel normal. That's definitely a huge difference between LASIK and Smile.
Absolutely. And Robert, if I can just go back to one of the comments you made a moment ago about the Visimax laser. In my opinion, the engineers did an amazing job planning this laser. They made it much more patient friendly. It's very comfortable. The fixation target moves to the focal point of the patient's prescription, so it's less scary. It's low pressure. They maintain vision. And the treatment is centered on the visual axis, whether it's a Smile surgery or whether it's the flap that it's making. So they put a lot of thought into this machine to make it better for surgeon and way better for patients compared to the other lasers I've used, the Itrace FS60 or the Wavelight FS200, which is a flat patient interface. It smushes the cornea. You get a CRAO, and the patients are miserable because of it goes black, it goes dark, and they have a lot of pressure. So none of that happens with the Visimax. Are you guys finding the same thing with your patient base?
Of course. And also the less subcon hemorrhage.
Yes.
In fact, during the Smile procedure, you can actually give them some Alphagan or Lumigan or something, Lumify. And then when they walk out, their eyes are completely white. And they're like, wow, my eyes are even better looking than they were before. Whereas the LASIK patients, they have red bloodshot eyes and sometimes, subcon hemorrhage. I operate on an actress, famous actress, and it was one of my first few Smile procedures. Like I hadn't even done
Wow, that's great.
And this lady had 30 million followers on Instagram.
Wow.
And our director said, what procedure are you going to recommend for this patient? I said, well, we're going to do Smile, and then her eyes will look great for the camera. So we did, and in 2015, pretty much the next day.
So we're going to talk about 3 main domains that were addressed in that paper published in April of 2025. So the first bucket is going to be indications. We answered 1 clinical question with 4 recommendations. The second bucket of questions is going to revolve around surgical planning and technique with 6 clinical questions and 16 recommendations. And then the final bucket is going to be talking about complications. There are 8 clinical questions about that and 18 recommendations. And then so the way that the evidence was graded and the recommendations, it was graded on a level of A, B, C, D. So a level of A was high evidence quality, B was moderate, C was low, and D was very low. And then the recommendation strength was based on either strong or conditional. And so based on those different parameters, we were able to come up with different recommendations addressing the different clinical questions that we wanted to address. So let's look at the very first one. So the first question was, or the first, I guess, recommendation was keratoconus is a contraindication for KLEx. And that had a very strong indication. And there wasn't really, the estimated effect is extremely different to the true effect. Do you guys have any comments about keratoconus being a contraindication to KLEx?
This is no surprise. And really, since day one of commercial usage, we pretty much took the stance that if a patient is not a LASIK patient, they're not a SMILE patient. We didn't really fall into the trap that there was greater biomechanical strength with SMILE versus LASIK. We just simply, yeah, you may have less ectasia with SMILE, but it's not a free pass. So anytime you're weakening the cornea with a lamellar procedure, it still holds that you want to avoid not just keratoconus, but even any form-fruste keratoconus. And I think that's the one thing that needs to be clarified from the paper is anybody showing any signs of even form-fruste keratoconus should be ruled out as not a candidate for a lamellar procedure, SMILE included.
I totally agree. I think we use the same criteria. In fact, in our practice, if the patient has higher risk, we don't even know if they have keratoconus, but if they're at higher risk of developing keratoconus in the future based on parameters like age or abnormal balloons or things, we kind of move them to a procedure that doesn't remove corneal tissue. Not even to recommend PRK in general, unless they don't qualify. They're hyperopic or something. So, but yeah, I totally agree. Even though there is some evidence and some papers and some studies that show there's a lower incidence of keratoconus compared to LASIK, we use the same shape.
Yeah, I agree. I think that the candidacy for SMILE is similar to the candidacy of LASIK. If I would not do LASIK on them, I would not do SMILE on them. SMILE has a smaller range of just being approved for myopia right now. But in the beginning, I think there was some confusion 6 years ago when I started doing SMILE, where some practitioners were suggesting that perhaps the patient's kind of on the edge for LASIK, but they're a good candidate for PRK. Maybe they'd be a good candidate for SMILE. But I think the evidence is very clear that if you wouldn't do LASIK on them, you should not be doing SMILE on them. And then what are your thoughts about optical zone and tissue removal with SMILE?
I pretty much follow the same parameters of what I would do as far as tissue removal with LASIK I do with SMILE. And my SMILE practice effectively since 2017, now 9 years, is 95% of the lamellar refractive surgery I do. So I do LASIK for just a very small number of patients, either really high astigs beyond what we can do with SMILE. So what I'm effectively doing is doing a 6mm optical zone for astigmatism. I know a lot of folks will do 6.5 with transition to 7, but I do 6 transitioning to 6.5 and have had really good results with it. And so as far as the depth of ablation, I will go to 250 residual bed. I have no problem with people saying stay at 280 or 300.
For myself, I try to keep the optical zone the same for all patients. If there's a concern that we have to reduce the optical zone because of tissue amount of residual bed, then we'll move to a different type of procedure, like a phakic lens. But in terms of the optical zone, when you program 6 into the astigmatism, it has a blend zone to 6.5. And then for sphere, I use 6.5. So it's in essence the same optical zone. In terms of residual stroma, I usually go for about 280 if I can. It's very rare I'll go down to 250 these days. SMILE does remove a little bit more tissue. And then also we're starting deeper in the cornea, which is supposed to help actually preserve the strength of the cornea because the anterior lamellar fibers are supposed to be stronger and kind of avoiding that. But psychologically, you're going deeper into the cornea. So that's that. It doesn't, we don't really know 100%. So I just use the same criteria for LASIK and SMILE in terms of residual bed. And I think that's very safe.
Yeah, I agree with both of you. I try to stay, I will get down to 250 like John will. My preference, of course, is stay at 280 if possible, or 300 even. I even have my staff call out to me from the screen if the number is less than 300 to say like 290 less than 300. just to make a point of it being under 300 so we're all on the same page. And the one nice thing they have, outside of the US that we don't have is the ability to adjust the cap thickness. So we're stuck at 120 here in the US, but of course they can go down to 100 microns everywhere else, which gives them more room. And just like you guys, I'm a smile first practice. And so if a patient qualifies for smile, that's what they're getting. But there are a couple of times where if I was trying to preserve tissue, I might consider thin flap LASIK, but I still like the point of biomechanics and less dry eye smile than for LASIK. Moving along here, we talked about the optical zone settings, 6.0 versus 6.5. My only concern with going to a 6.5 zone with astigmats is having a smaller corridor in the periphery. If a patient moves, you might have some difficulty getting, all the way out. Have you guys had any issues with that, or is that just a me issue?
Now, I kind of follow in suit with you, Sonny. I do know other docs will do 6.5 for the astigmatism, hoping, again, that's going to blend out to 7. And that just leaves a window, as you say, of 0.25 millimeters on either side versus what you and I do. We leave a window, a working distance of 0.5 at 360 degrees. The folks that want to do the larger optical zone, 6.5 transition to 7, the thought process is there's less regression. And I certainly understand where they're coming from. I just see very little regression. And so I feel very comfortable with a 6.0 blend to 6.5 for the astigmats. I certainly appreciate the other folks and what they're experiencing.
Great.
Yeah, I don't really see that much regression with the astigmatism. So I've been very happy with the astigmatism treatment. I mean, our enhancement rate is like 0.2%. Maybe our
That's
patients have lower expectation if they're happy and astigmatism or not.
I think that point's very well taken by me, Robert. I think the astigmatism effectiveness of smile is really amazing. And I compare that to excimer laser. I think we get better astigmatic results with smile, case to case than we do with LASIK. Again, LASIK's great, but smile I've found is even better.
Now, are you guys marking for cyclotorsion? I am not.
I do.
I'll tell you that right now. Yeah.
I continue to be a marker.
We heard you mark everybody. I mark at 2 diopters and above. And how about you, Sonny?
I don't mark. I think the first time I tried to mark, a patient moved and, scuffing the epithelium, and we ended up canceling the surgery. And so I think that just made me gun shy, after that. But I should probably just have a better technique and start marking. But even with me not marking, we're having excellent results. So it hasn't prompted me to go and start marking patients, quite honestly.
Yeah, and I think if I could add 2 things there. I mean, Steve Schauhorn has repeatedly said in the FDA study, we didn't mark and we got great results. And so let's say I do mark, I mark every patient. What is my cyclotorsional adjustment typical? 3 degrees, 2 degrees. I mean, rarely will I even get up to 7 degrees, sometimes 5 degrees, but I would say the majority, if I'm going to even alter or adjust or cycloregister to my marks, it's maybe, again, 2-3% or 2 to 3 degrees.
That's amazing. That's great. That's great.
Yeah, we'd love to see your little mini study on that. That's pretty amazing.
Yeah.
Well, we mark with using one of our lasers that does iris registration. So it's a lot easier for me to mark. So I don't have to do it with the slit lamp. We just make the mark when they're already lying down and make the spots, because you got to make the spots centrally, right? You can't do it at the limbus in order to see the marks when you dock. So some people will calibrate the smile, the crosshairs, so that they're always calibrated so that they can just see it all the way in the periphery. But usually it's off because if you change the PD or something, that's going to make the 180 can be different. So you could line up the oculars to it at the beginning of the day. So that's one way you could do it. Then you can mark at the limbus. Otherwise, you have to mark in the central 6 millimeters or something for you to be able to see it after the eyeballs dock. Yes, to hear that a lot of people are getting good results without marking.
The other point with that is, I'm in the Midwest, so we still have a large percentage of blue and green irises where marking becomes very difficult with the purple marker. As you say, if you're outside of the pupil and now you're overlying a brown iris or very, very dark brown iris, you will not see those purple marks. So it's ideal if there's a blue iris, you can see the purple marks really well. So that's just another kind of a demographic issue you may run into with if you are marking.
Great tips, guys. Those are really good tips. So let's talk about centration and how you manage decentrations. So, I think we all have the 800s and the 500s, and we've gotten used to docking with these machines. And, I'm still asking that on both the machines, I'm still asking the patient to look directly at the flashing green light as I'm docking. And I'm asking them again, are you staring directly at the flashing green light? And their yes, no answer will then enable me to continue the procedure or disengage and redock. Are you guys using the machine to help you center, or are you still relying on the patient like I am?
I'm doing both. That being said, I'm only using the VisionMax 800 at this point. One thing I would probably say that might be the listeners may have interest. So we've been doing commercial SMILE since 2015 for Sphere, and then compound myopic astigmatism started in 17. That's part one. Part two is as a kind of the I don't know what you call the guy, the 1-800 SMILE problem person, Bill Wiley and myself get these calls. I will tell you, in the time I've been doing SMILE, I have yet to see a decentered treatment. So we can all go back to, prior to centration with excimer lasers, some massively decentered LASIK treatments or PRK treatments. I simply have not seen a visually significant decentration yet. And I get presented a lot of cases. So maybe they're out there, but the one thing I can say is the system that the patient to fixate on the light and the surgeon doing, verbal anesthesia and talking them to the fixation light, decentrations are exceedingly uncommon.
I agree with you. I remember Conrad Filatowski, when I was first starting doing SMILE, and I went out to visit him and train with him. He sent me a case like a month or two later and said, hey, look at this decentration. He sent me the topography, but he said the patient's vision is 20/20. And so it was interesting, to your point, John, how even with decentration, the visions are excellent.
Yeah, I think that the rationale behind that, Sonny, is that we effectively have a 6 mm optical zone, and we don't with SMILE, unlike with laser vision, with excimer laser vision correction, the optical zone tends to shrink with time. It doesn't with SMILE, since it's a lenticule extraction. It stays the same, and maybe with the draping effect, it maybe gets a little bit larger, but it certainly doesn't shrink like we do see with excimer laser ablations.
My comments would be, first of all, the optical zone and the transition zone. If I have a couple slides of that where I show patients with a SMILE treatment, it's much larger. So that's one for every type of treatment was -2 to -10 compared to LASIK. So that helps with little small decentrations. Number two, with LASIK, it's only been more recently, and I'd still say half the surgeons are still not centering on the green reflex. So these topographies that we're talking about with LASIK decentrations, a lot of times these lasers, the LASIK procedure was centered not on the reflex, corneal reflex, which we think is a lot closer to the first Purkinje reflex that you're supposed to be the visual axis. So I think those are two factors, but I think it's because of the optical zone and transition zone so forgiving, I don't see any patients with symptoms. And I think that's the key.
Yeah, great point, Robert. I always mention in our courses that if we were doing SMILE optical zones of 3 mm, if you're off just maybe a 1/10 of a millimeter, you got a problem. With a 6 mm ablation or 6 mm photodisruption, I think you could be off quite a bit more and not have symptoms. But again, what is our level of decentration with SMILE? I think you're probably on average, I would say the overwhelming majority of the patients are less than 0.3 mm from center of fixation. If you look at the screen on the 800, it's almost always less than 0.1, maybe 0.2, probably worst case scenario is 0.3.
That's a good point. Let's talk about refraction. One of the recommendations from the study was to do a cycloplegic refraction for myopes because of the worry about accommodation. Are you guys cycloplegic all of your patients?
They do not. We do fog manifest. I mean, if I was really found a problem, we just found over the years, doing so many cases, we would test, fog manifest versus cycloplegic, and we really did not find any difference. So fog manifest is our protocol.
Yeah, I think for us, it kind of started during COVID because, we didn't want to be dilating patients and being, with all these different things. So we started a protocol where we only dilated people who were higher than a certain prescription because we're going to do a dilation exam anyway for retinal reasons and, to look at the macula better. And so we have a criteria, I think it's like -7 or higher, we'll dilate and do cycloplegic. If they're hyperopic or mixed astigmatism, we'll do that, which obviously is not related to smile. But for the myopia, unless we see that there's a difference between the habitual versus, so we usually don't, but then of course, on a case by case basis, we will get more information if we feel like they're accommodating. And I think a good refraction is very important, and to fog or the red green or, and to standardize it between all your optometrists is very important with the same, testing conditions.
I agree with you because that'll affect your nomogram and your outcomes depending on who's refracting. And I still do refract some of my patients, and I will do the red green balancing and the prism balancing. And I do not cycloplegia everybody. To your point, Robert, I do all hyperopes and mixed astigmats and some high myopes if I think they're accommodating based on the testing, some variability in the testing results. But I did an ophthalmologist actually from Ohio last year. And when she came in and she knew what her refraction was, and I said, well, let me just test it myself. And I did it. And I got her to be a half diopter less myopic. And she didn't believe me. So I went to a different room and we did it again. And she's like, that's crazy. She's like, I was refracted by someone else at another place and they were getting what I was getting. And I'm like, well, I'm telling you, I don't think that's accurate. And I didn't have to cyclo her. And she came out, 2015 the very next day. Even as somebody who's a experienced refractionist, sometimes when they're young and healthy and they're over-lighting themselves, but there is a way to get that out without having to cycloplegia them, I guess my point. So Robert, you talked about knowing who refracted, like which optometrist refracted and whatnot. Tell me about your nomogram. Do you have a different nomogram per optometrist, or like, how's that working for you?
Yeah. So usually when we have a new optometrist, we have them refract 2 optometrists that are, or, if it's a new optometrist, we compare to the other optometrists and have them refract the same patient to make sure they're refracting the same way and calibrate. After they go through, let's say 10 to 20 refractions and it's consistent, then we basically allow to use their numbers as one of them. So we only have one nomogram for Disurgeon. And our nomogram is actually a lot more, we add a lot more to the nomogram than what's outside of the box. So I think standard is to start off 10%, add 10% to the sphere and probably keep cylinder the same. And then some practices go up to 11, 12. Ours is a little bit different. Ours kind of changes because we entered it into the visualized software program. So ours is dependent. We have a lookup table. It depends on what the prescription is. And then we'll program the laser according to that. And that's been pretty much right on for all these years.
That's awesome, which is why your retreatment rate is so low, right?
Right.
Yeah, that's awesome. Johnny, you using Visualize as well?
Absolutely. I thought I had a great thing going with a Excel spreadsheet. I had started, I think, in residency and fellowship and used it for years. And I thought it was just a gold mine until I used Visualize, and Visualize got our results even better. So I'm a total believer in Visualize software at this point. Like you all, we standardize our refractions with anybody that's doing refractions, ODs in our practice on the refractive team. And I have a nomogram, and we do add to the sphere and we do add to the cylinder correction more and I should take a step back. I have 3 nomograms that work off of the algorithm of the laser. And one is for with the rule, one is for against the rule, and one is for oblique. And we definitely have different results on astigmatism based upon the orientation of the astigmatism. We tend to have to treat more cylinder correction for with the rule than against the rule. But again, our enhancement rates are basically identical across those groups, again, because we're using Visualize. And our outcomes have just continually get better. We're probably, I don't know if we're at the final point, but we're we're always adjusting and following the algorithm. And most recently, we had the nomograms placed onto the lasers, so I no longer have to look up a sheet and do it handwritten. It's just automated in the system, so it's really nice.
That's awesome. That's great. And that's why you both have such low retreatment rates.
This concludes the end of part 1 of the KLEx study review. Please visit CRST the podcast to listen to part 2.